Thank you for this opportunity. We're going to revisit some of the data that's already been presented. So in-stent restenosis, as we've all kind of talked about so far, is due to angioplasty, injury, atherectomy, or stents causing endothelial dysfunction, ultimately creating cascade of platelet activation and inflammatory cells, creating a very prolific vascular smooth muscle cell and extravascular matrix inside the stents. When you look at the literature, you can see that the rates of in-stent restenosis is quite variable and have definitely improved with the utilization of drug-coated balloon stent coverage. However, anywhere from 5 to 30% of stents in the FEMPOP region are going to end up requiring some sort of reintervention within that first year. So this is still a problem we're going to continue to face, particularly from the outside hospital. So drug-coated balloon angioplasty. This is kind of one of the more modern go-to treatments for ISR. The FAIR trial was a randomized controlled trial that compared DCB to POBA. And the mean lesion length that I want to kind of pay attention to as we go through some of this data is around 80 millimeters. No difference between POBA and DCB with regards to patient demographics or the lesion characteristics. What you can see is that DCB significantly reduced the rate of recurrent in-stent stenosis at 1 year. And then you can also see that the freedom from TLR maintained throughout that 1 year period. You can see the Kaplan-Meier curves continue to deviate. So you get that extra protection from the drug-coated angioplasty throughout that full year period. This data is reinforced with other trials. So you can see the first trial up on the top of the screen demonstrates an odds ratio of recurrent stenosis with POBA alone compared to DCB and ISR is nearly 3. When you look at it specifically in the diabetic patient population, you also see a conferred significant rate of freedom from TLR with the DCB compared to POBA alone. And then in our final trial, you can see this is not only supported at a 1 year, but also at a 2 year mark, you still have that improved benefit with DCB compared to POBA. When you start talking about the use of DCB, you also want to talk about debulking. I know we've touched on this a little bit, and I just want to bring up some of the data. So you can see Jetstream, they actually have 3 different trials. The first one was Jetstream ISR, and this was really just a feasibility study to demonstrate that this was safe and that there was no device-stent interaction with this rotational aspirational atherectomy. The next study that they performed was Jet ISR, and this was Jetstream with POBA, and showing moderate outcomes. So you have TLR at 6 months around 80%, but 1 year drops down to about 60%. And the nice randomized controlled trial that I was very interested in seeing the results from was the multi-sender Jet Ranger. And what this was doing was looking at Jet plus DCB versus PTA plus DCB. So to see, is this the drug-coated balloon angioplasty that's making the difference, or is it actually the debulking as well? Unfortunately, due to a variety of circumstances, including COVID, this trial was halted before it could enroll its total of 255 patients. The data was published of the 47 patients, and it was really just exploratory at this point. But no bailout stenting in the Jet arm of the group, and no distal embolization. And for the patients they did have, the 1 year freedom from TLR was quite remarkable in both. Really, the workhorse, though, that we're talking about in the debulking range is going to be your laser atherectomy. This is the one of 2 devices that are approved from an FDA standpoint for ISR. So laser atherectomy is going to allow for photoablation by photochemical and vapor bubble disruption of the molecular bonds, which is really critical for your ISR, your intimal hyperplasia. So the EXCITE ISR trial is a pretty pivotal trial in that it was a well-designed trial. It was a randomized controlled trial, laser versus POBA alone in a 2-to-1 ratio. The length had to be at least 4 centimeters with at least 1 single vessel runoff, and this was actually terminated early because of the superior results you got with laser atherectomy compared to POBA alone, with a 50% reduction of TLR at 6 months. As you can see, you have a lot of initial benefit in your freedom from restenosis in that early portion of your follow-up period, but that does carry out through your 365-day mark. Of note, we did talk earlier about the low numbers in your Kaplan-Meier towards the 365-day mark, but you also have to understand that the trial was terminated early due to those nice results in the beginning. When you look at the 6-month mark, you can see a significant improvement in primary patency and freedom from TLR in the laser group. And then when you look at this in sub-cohorts, you can see that laser benefited patients who were older, who had previous ISR treatments, a small reference vessel diameter, and advanced lesions such as TASD and occlusions. This was a really nice retrospective review that actually looked at laser in DCB compared to laser in PTA. So seeing, again, trying to delineate, is it the drug-coated or is it the laser atherectomy? And what you can see is that recurrent occlusion and TLR rates were significantly decreased when you combined laser and DCB compared to laser alone. When you tip this out to 2-year follow-up, you could also see improved freedom from reintervention down to 2 years with the combined laser and atherectomy, laser and DCB group. There was also a nice randomized controlled trial that looked at a very complex lesion, so it's all in-stent occlusions, and it looked at laser and DCB versus DCB alone. And again, what you're seeing is that patency at 6 months and 12 months were significantly improved in this pretty tough patient population when you had the combined laser and DCB compared to DCB alone. And again, also improved limb salvage rate. So drug-eluting stents. There is not a lot of data out there with regards to relining with drug-eluting stents, but I think most of us would agree if we're going to reline, we're probably going to only reline once, so it's a limited repeat intervention. The most elegant kind of data that's out there is a subset analysis from the Zilver PTX study, and it's 108 patients, and what you can see is that the mean lesion length in this study is 133 millimeters, with over 30% of these lesions being greater than 150 millimeters, and 30% of these lesions were occluded. Had very nice procedural success, around 98%, and 1-year primary patency was nearly 80%, and when you took freedom from TLR was 80% at 1 year and about 60% at 2 years, so you start to lose that benefit. In comparison, covered stents is a nice option. It prevents the repeat ingrowth of that intimal hyperplasia between the stent interstices into the stent. Although the problem with this is that you have to be aware of you're going to lose your collaterals and possibly develop edge stent stenosis, which will place you at acute limb risk if this were to occlude in the future. This is more often considered in places where you have recalcitrant stenosis that has not been readily treated with other interventions. Mobile intima that you might see on your IVUS or on angiogram, when you end up getting into a subacute component and you haven't really cleared that and you're worried about it embolizing. Recurrent stenoses, and sometimes people will use these also in the setting of a complete occlusion to reline your stent. The RELINE randomized controlled trial, which has been discussed here, is obviously it's a Viabahn stent compared to PTA. What's important is to acknowledge what these patients are in this patient population. So it's a randomized controlled trial, but these were long length ISRs, so 170 to 90 millimeters in length compared to your laser and your DCB trials. Anywhere from 25 to 50% were totally occluded, and you had a 100% technical success with Viabahn, and 80% success with your PTA alone. But then look at your 12-month primary patency rate. Your Viabahn is going to perform very well, 75%, but this is a hard lesion group because your PTA is only performing at around 28% at that 12-month period, which is significantly less than what we've been seeing in the other trials. And this is your Kaplan-Meier curve taking it out to 12 months. You can still see a divergence of these two, demonstrating a prolonged effectiveness with the Viabahn stent in these more difficult lesions of ISR. So in conclusion, ISR continues to be very prevalent despite current antiplatelet and drug-eluting technology. Advanced treatment yields 1 year freedom from TLR ranging anywhere from 60 to 80%. I do believe there's strong data to support the use of DCB and atherectomy for debulking over angioplasty alone, and there is some retrospective or small randomized controlled trials that suggest that atherectomy and DCB combined can produce superior results to one of the individual treatments alone. Studies evaluating relining are often looking at ISR lesions that are more complex or longer or complete occlusions. They do show good data efficacy, but lacks direct comparison to our other modalities such as DCB and atherectomy. And covered stents are a good bailout option for recurrent ISR, but we just have to be careful that we monitor for edge stent stenosis, as loss of these collaterals can lead to acute limb ischemia should they occlude. Thank you.